What if one of the most common reproductive disorders in women went undiagnosed in up to 70% of cases? What if its symptoms affected your skin, your hair, your mood, even your ability to become pregnant? And yet, most women never even heard about it until they were struggling to conceive. That's the reality of PCOS, Polycystic Ovary Syndrome. Welcome to the Informed Woman magazine, where we decode complex women's health issues with compassion, science, and clarity. Today, we're unpacking PCOS, what it is, why it matters, how it affects your entire body, and what you can do about it. Whether you've been diagnosed, suspect you might have it, or want to support someone who does, this episode is for you. Polycystic ovary syndrome affects 8 to 13% of women of reproductive age, and yet, shockingly, up to 70% of cases go undiagnosed. The condition is slightly more prevalent in Black and Middle Eastern women than in Chinese and white populations. But PCOS isn't just a reproductive issue, it's a metabolic and endocrine disorder, characterized by elevated male hormones, insulin resistance, and irregular ovulation. In simple terms, PCOS affects how your ovaries function, how your hormones behave, and how your body responds to insulin. PCOS shows up differently in every woman. It can look like excessive hair growth on the face or chest, acne that persists well into adulthood, or sudden scalp hair loss. You might have irregular periods, or none at all. But PCOS also carries long-term health risks, including type 2 diabetes, cardiovascular disease, and increased rates of anxiety and depression. The physical and emotional toll can be overwhelming, especially when the diagnosis is delayed or missed entirely. So, how is PCOS diagnosed? According to the Rotterdam criteria, you need 2 out of 3 of the following. 1. Irregular or absent ovulation. 2. Signs of high androgens, either physical, like acne or hair growth, or confirmed through blood tests. 3. The presence of polycystic ovaries seen on ultrasound. On ultrasound, doctors look for 8 to 12 or more follicles in each ovary, measuring between 2 to 9 millimeters, and/or an ovarian volume greater than 10 milliliters. But here's something important. You don't need to have visible cysts to have PCOS, and not all cystic ovaries mean PCOS. Despite the name, PCOS isn't primarily an ovarian issue. It's actually a neuroendocrine disorder, meaning it involves the complex interplay between your brain and your hormones. The hypothalamus in your brain acts like a hormonal clock, releasing pulses of GnRH, or gonadotropin-releasing hormone. This tells your pituitary gland to produce 2 key hormones, LH, which is luteinizing hormone, and FSH, or follicle-stimulating hormone. FSH helps follicles mature. LH triggers ovulation. In PCOS, this hormonal pulse becomes unbalanced. GnRH is released too frequently, which skews the LH to FSH ratio in favor of LH. That high LH stimulates the ovaries to overproduce androgens like testosterone, and that's where the trouble begins. Excess androgens disrupt ovulation, cause acne, unwanted hair growth, and hair loss, and are linked to insulin resistance and weight gain. But the story doesn't end with hormones. Many women with PCOS also have insulin resistance, which causes the body to overproduce insulin. High insulin levels further stimulate androgen production, creating a vicious cycle. This can lead to abdominal weight gain, high cholesterol, and long-term risks like type 2 diabetes. And elevated androgens also reduce sex hormone-binding globulin, which makes more testosterone freely available in the bloodstream, exacerbating symptoms. So PCOS isn't just a fertility issue, it's a whole-body metabolic disorder. Currently, there's no cure, but there are effective treatments to manage symptoms. For women not trying to conceive, the first-line therapy is often the combined oral contraceptive pill, which helps regulate cycles and reduce free testosterone. Anti-androgens, like spironolactone, can block testosterone's effects. Metformin, a medication commonly used for diabetes, improves insulin sensitivity and may help restore ovulation. It even appears to influence the gut microbiome, which is emerging as a major player in PCOS outcomes. For those trying to conceive, ovulation induction with medications like letrozole or the gonadotropin, FSH, may be necessary as part of an IVF procedure. Treatment is highly individualized and should always be tailored to your specific symptoms and goals. Here's the exciting part. Our understanding of PCOS is evolving rapidly. Recent studies have revealed key roles for special neurons in the hypothalamus, called KNDI neurons, which help regulate the GnRH pulse that starts the hormonal cascade. New therapies are targeting these pathways, including neurokinin 3 receptor inhibitors and selective kappa opioid receptor agonists, which may normalize GnRH and LH signaling. Other approaches aim to modulate kisspeptin, a hormone essential for ovulation. And on the genetic front, researchers are now investigating epigenetic changes, chemical modifications to DNA that affect gene expression. These may explain why PCOS behaves differently in different women, and why it sometimes runs in families. PCOS is a complex, multi-system condition, but it is not a life sentence. With the right information, diagnosis, and care, women with PCOS can lead full, healthy lives and achieve their fertility goals if they choose to. If this video helped you better understand PCOS, give it a like, subscribe, and share it with someone who needs it. Have you been diagnosed with PCOS? Or are you in the process of finding answers? Drop a comment below. Your story could help someone else feel seen. And don't forget to turn on notifications. We release new videos every week on women's health and reproductive care. Until next time, stay strong, stay curious, and stay informed.